Swayam Prabha. Digital India. Educated India.
Welcome friends once again to this NPTEL MOOC module on health economics. This is considered to be a little different than the existing modules because of its coverage and its latest debates. Especially this is relevant after COVID-19 where lots of emphasis have been given by different health systems, by different framework. Because it has been felt in the world that how health systems are functioning and why these functions are not that sufficient. In the pretext of this, I think it is good to study economics of health systems. This is the unit we have mentioned, and within this first the lecture is on health systems. And we will understand in this lecture on the organizational structure that is relevant for how much funding is actually available and how it is utilized, and to what extent rationing is required, and what are the institutional structure and incentive that really shape off the system better in terms of their efficiency and especially incentive to efficiency implicit in the alternative system is quite relevant. Now coming to the part of health system is through funding and rationing. First question is what should be the proper level of healthcare funding, and what is then what is the need, and then especially when we are saying proper level of healthcare funding, we are supposed to debate about healthcare funding. The political debate is most important so far as healthcare function is concerned, or funding is concerned. It is to be asserted that all healthcare needs should also be met. Then we will also emphasize definition of need, what is called need. On the basis of need only funding is actually met or addressed. So, how to define the need? Okay, so but defining need based approach is very complicated, and how to simplify that is part of the discussion. So, need is not the size of the health problem a person is dealing with, but rather the feasibility of a successful intervention to eliminate or lessen that health problem as mentioned by Matthew in his paper in 1971. So, successful intervention is the focus to eliminate and lessen the problems in the healthcare system. So, it is not just the size of the problem that really matters so far as need is concerned. Therefore, need is the ability to gain from a service, and it should be met if the benefits outweigh the cost. Now, to understand the need and the allocation, fund allocation, we should understand the basic demand and supply function, where the need based approach or the willingness to pay etc. can clearly be addressed. So, where we will be discussing about marginal social value or social cost or the private valuation of any services, health services particularly. So, the help of demand and supply matters. We have already clarified last time that in our previous lectures how demand and supply actually define the rate of contract for the buyers to afford for any healthcare available, and to what extent discounts or the rationing in terms of access should be provided. It starts with the basic framework of or marginal valuation related to the services or the commodities as against the cost. Therefore, demand curve can be visualized as individuals own calculation and or own valuation that is usually measured through willingness to pay of the commodities and services. So, in the as I have already discussed in my very first week of the module is on demand and supply of healthcare. Here we are reiterating the structure in terms of the benefits received. When we are saying demand curve, left hand side or the left portion, basically these areas defines who places the most value on the benefits and how they are ready to pay. Okay. And at the right and lower end of the demand curve are those who place a relatively low value on the advantages to themselves and are hence willing to pay less. Basically again lower end and upper end, it is quite obvious that the valuation would be different. At the upper end the valuation is through the elites and the lower end it is the non-elites or the other classes. So, assuming consumer sovereignty Q star is actually the level of provision, and by setting the price at the level of marginal cost, as we know that supply is actually a sum of marginal cost curve or the integration of marginal cost curve at ith level of the supply. Now, if it is actually a price is set, it is actually setting at a certain level of marginal cost. If that is perfectly matched with the marginal valuation by the buyers or the demanders who are demanding for the health services, then an equilibrium quantity is settled, and that quantity is the best quantity to be a system should be providing. So, the price mechanism is the simplest way to ensure that healthcare resources are actually distributed to those who value their own demand the most. And as we know that if there are some mismatch from the equilibrium, maybe somewhere here, or maybe if price is set somewhere here, if there are any points in between, not at the center or not at the equilibrium point, there will be invisible hand which will drag to the center. Okay. It is a typical demand and supply function which we have read in our economics theory. So, and accordingly the value is determined. In public health system in particular, funding levels should be set such that it allocates the resources to high value and away from the low value demands. Okay. So, especially in supply curve which you have said, it is basically the the additional cost of every unit of a service being provided. Now, due to market failure, we want to mention here that the equilibrium quantity which is to be restored by the system may not be actually defined to be the best. And so, market failure basically the market is not in a position to properly value the entities, that is demanded and the suppliers. So, due to market failure in other regions, no society and policymakers consider that value derived from demand curves for healthcare at all satisfactory. Okay. And there are three significant reasons why private and societal demand differ from one another. So, the way we emphasize or project the value, the society may not be actually projecting. Okay. So, individual demand and the societal demand for any service might be different. It depending upon proper contract in the market. It has to be competitive structure in the market. But if the market is not functioning very well, it is already conceived to be biased or conceived to be erratic. In that case, the valuation of any product or the services is not going to be correct. So, now we are trying to define why private and societal demand differ. It is again because of the ability to pay. as well as willingness to buy. And in comparison to demand of poorer people, the demands of richer people are more weighted. The health sector resource allocation, if society or policymaker believe that demand should be equally weighted, values derived from demand evidence alone cannot be relied upon. So, and second one is so far as private and social differences in valuation is concerned, another factor that attributes is called lack of information. That gives in terms of ranking, that helps in terms of prioritize individual demand as against societal demand. Okay. So, they could place high value on interventions that are limited or effect is limited or limited effective because product claims have misled them. And these restrict the extent to which the demand curve can be understood at the person's actual assessment of the available health interventions. So, basically this roughly discusses about if the information is not reaching correctly to all the people, then the valuation will be different. Third one is called externalities. Most of the time people do not consider benefits when valuing their own benefits, like disease, disease transmission with vaccination, it reduces to another one, reduced risk of disease transmission received by others. And like in COVID time, there are number of way where you might have seen the externalities or the information that is reaching to others have actually hugely inspired others to value the product differently. Okay. So, given the perception of one person, that immediately transmit to other one. Yes, the information network might work better, but the externalities might be giving a different indicator to value differently. Not necessarily the time which we have started with evaluation would be same in period 2. Okay. So, with the value and order demands for the use of resources from a social perspective, a social demand curve can be hypothesized, and accordingly we can define how they are different. So, private demand and social demand function are different. In this graph, the demand structure which we presented is largely called individual demand function, but now we are trying to differentiate the private demand as against social demand. Here we are mentioning as private demand, here it is social demand. So, basically it is the individual addition of all successive demanders and their demand or their marginal valuations defining the social demand as against the private demand. It is similar to the context of market demand curve as against the individual demand curve in economics. Social marginal value is also diminishing with the rise in the access of any service or quantity, except some particular services. There are some exceptions we used to study in demand theory. Let us consider an example called vaccination in this case. Says let vaccination may be for measles, maybe for BCG injection, etc. The individual's values of immunizations are likely to be quite low, and the private market demand curve is drawn as in PD. So, whereas society as a whole, it is quite essential. It will be for the society it is essential, it will be controlling, whereas an individual might pursue that somebody has already taken vaccination, it hardly impacting me. Likewise in COVID, even if there are number of restrictions, lockdown was imposed, still people could not able to follow strictly. They value the instruction not so seriously. Even people didn't consider the COVID vaccines not seriously. They had the perception that if somebody has taken, then it will be hardly affecting my body. Okay. So, individual valuation is considered to be less viable or less demanding, hence the willingness to pay for this product is very less. Whereas as a society, the planner for the society point of view, or the planner is actually projecting this to be very good, and hence society requires more emphasis to be spending on this particular direction. That will be eventually controlling all individual need. In short, the all individual perception is added, and in horizontal addition will get for each price contract will have higher demand. So, this demand every time is actually projecting for the or estimating for the social demand functions. Now, accordingly, when we say individual demand, we define it through users perspective as well. Who is projecting or presenting the willingness to pay, or the or their payment structure, or their demand for different services. Especially when we are citing any service unit, it varies from better educated persons to less educated persons, and it also varies from richer class to the poorer classes, because they cannot able to afford, poorer classes section may not able to afford the high end services. Therefore, their willingness to pay would be considered to be lesser. Similarly, at the societal level, so far as ST is concerned or social marginal value is concerned, we usually define through users at highest risk of contracting and passing on the disease. If it is that, then the valuation will be very high. If it is a lowest risk, then the valuation will be certainly lesser. Okay, so once the vaccination is implied or already effective, and some of them already taken, then there is a possibility of reduced risk of disease transmission, and the another person will be actually taking it considering this at a very lower value. Hence, its demand curve is drawn, which is estimated at a lower level than that of the social marginal value. Now, considering this, I think I have already mentioned that it is dependent on affordability, it is dependent upon the education, and whereas in social context, it depends on the extent it contracts. It depends on the rate at which it diffuses to other people. So, and also it depends on the risk. Okay, so risk is one of the factor, and that is not the one which we find it too relevant for individual valuation. So, I think based on the adjustments for social value from private values which are likely to increase value, the social demand curve lies to the right of the private demand curve. Then what do you mean by adjustment, which I have already started discussing. So, what kind of adjustments are made? Now, adjustment like full understanding of benefits of immunization for the individual, like correcting for imperfect information. And if the benefits is fully observed and understood, in that case adjustments are considered to be faster. Okay. The effect of immunization for other whose risk are affected, taking externalities as well. So adjustment for imperfections, adjustment for externalities, and removing well calculated weights, etc., will be actually countable enough for the adjustment to take place faster. Immunizing individuals at the highest risk of contracting and passing disease will be given the highest value. When the herd attains immunity, the marginal benefit of immunizing to the next person is actually 0. Okay. So, which is in fact happening in the post COVID period. Instead of being measurable things, social demand curves are usually conceptual based. Social values cannot be observed and can only be closely related to concepts such as benefits, QALY, quality adjusted life years, and disability adjusted life years, etc. Are some of the even databases available to get some perception related measures for different services. Now we are going to clarify you for the system to be working or functioning better, funding is required, the system without funding, and who funds it and where it is useful we are not discussing at this moment, but fund is most important. It of course depends upon the marginal valuation and its marginal cost of funding, and hence we will be emphasizing on optimum funding and underfunding. So, funding, what do you mean by funding? It is basically simply allocation and use of financial resources in the health system. Optimum provision and funding is where the marginal social value of the application of a unit of resource equates with its marginal cost. Wherever they are equalized, then we actually define this as optimum funding. In this figure, we find that the social demand curve, basically we have taken a parallel shift for simplicity. Social demand curve lies right to the private demand curve given the marginal cost valuation, that is the supply curve. We have the social demand, that is resulted here is Q double star and as against Q single star. So, at a higher level of funding must now be defined as optimum, and levels below that are defined as underfunding. So, any level once we define, and above to this is called optimum. Now, a higher level of funding, basically once we have defined this, higher level of funding must be defined as optimum, but optimum to be actually clarified very clearly. So, once this MC and MV are actually equalized, we usually consider this as optimum, but once it is below to this, if it is not attainable, the social marginal value is not attainable, this is basically a demand of the society, but your funding is coming short of it, therefore, the demand is actually not possible to be met, then in that case that is called underfunding. Let us clarify further. We are differentiating this. Healthcare system receives adequate financial resources to provide high quality care, ensure access to all, and invest in necessary infrastructure and innovation is called optimum funding. Whereas, healthcare system does not receive sufficient financial resources to meet the growing demand and maintain the quality of care. So, in our typical demand and supply structure, once the equilibrium is not attained, we actually define as underfunding, otherwise it is called optimum funding. Okay. So, now we are discussing the health system through institutional structure and its efficiency. A health system is defined by the relations between users, payers, providers and regulators. So, and who are the entities? Largely they are the individuals and the providers. In between, the flows of resources or the services are actually cyclical in nature. The flows might be through resources or might be through services. The provider of course provide the services and individual provide the resources for which the services could be made. So, it is not just this is so simple, in fact there are intermediaries, the regulators, there are the implementators and which are different, and those intermediaries actually act important role in the present system to deal both the entities. So, those intermediaries may be regulatory as government, maybe social health insurance funds, maybe regulatory bodies and others. There are alternative ways of organizing health systems that have implications for the ownership of health providing and financing institutions. They are internal governance structures and the flows of resources within and between institutions. Within the system, incentives really work much so far as meeting the individual demand through the providers, or the providers may be defined to be efficient enough, and those efficiency could be through allocative or technical. Now, what do you mean by allocative efficiency? Basically when the productive activity has been allocated to those products which consumers value in excess to their cost. So, productive activity has been allocated to those products which consumers value in access to their cost, whereas technical efficiency, it concentrates on using resources efficiently to achieve specific goal. How well resources are actually used to produce a given level of output or achieve specific objective. In the first case, we said how distribution matters, how we are allocating this to the consumer, and second case we are actually emphasizing on its productive use or into efficient use through technical management or approaches. So, incentive really matters. Incentive to pursue efficiency strengthen as institutions become more private, as of low powered incentive or high powered incentive. Now, it depends on if high powered incentive which operates in markets and low powered incentive which operates in hierarchical institutions, like big businesses and government entities. So, when market based operations are there, they usually called high powered incentives, and whereas in government system we used to have hierarchical systems, and the target of the government is not to distribute its profit, because there is no profit as a word in government system. So, usually the purpose of the government is allocative one largely, and that largely follow hierarchical incentive schemes, whereas market based might derive best result, that is why it is called high powered incentive structures. So, incentive within institutional framework entails qualitative evaluation of the balance of incentives and degree of strength. Some public sector organizations have well tuned to performance promotion systems with steeply graduated pay structure that attempt to reward achievement financially and may do so as effectively as profit sharing scheme. In private organizations, as I already mentioned, in public organizations that's really due to some forms of incentive, promotion based incentive, whereas in profit sharing scheme in private organizations is usually followed. And in teamwork, it is invariably challenging to align pay with performance. You might have seen some tasks are given actually to team. So, when team has resulted a bigger change, better output, in that case distributing or giving incentive individually is very difficult. It has to be treated on average or equally. Both public and private organizations have fixed salaries and poor career structures and weak promotion incentive, and whereas as we all know that incentives led to harder work and more focused efforts and improve performance. So, new way of designing or incentive case is very urgent to derive or to define health systems to be efficiently functioning. But however, incentives can be also perverse, or not necessarily all incentive is going to be always effective. So, different elements of the structure and design of the healthcare system may result in perverse incentives as well, like paying healthcare providers on a fee for service may encourage them to prioritize quantity over quality of care. So, and strength and value of private sector incentive is high if perfectly competitive model is actually followed, and so that it is actually a market based incentive where we have already defined called a high powered incentive structure. Profit seeking implies a concern with cost minimizing, in that case is actually called internal efficiency, and seeking to meet consumers demand where allocative efficiency is discussed. So, largely what is discussed is profit seeking if any is there, that is largely due to internal efficiency based structures where cost minimizing steps are taken, and or another efficiency is also made to derive more demand, that is through allocative efficiency. And in our chapter on efficiency, healthcare efficiency, you will understand the details of efficiency. So, and I think we have already covered this in our chapter. If you check our complete units, you will find in our chapter our unit number 10, a dedicated section is dealt called health efficiency, where we will be discussing concept of efficiency, data involvement analysis, deep software which is open source one, and with certain examples, and we will also clarify technical efficiency, internal efficiency, and other. So, more market exposure, as we already said, will be more rewarding in terms of better valuation or efficiency. However, market imperfection leads to more complex situations, as we know that if competitive structure is there, it is always good to be efficient, whereas in imperfection the incentive structure are considered to be very complex. A mix of incentives for various sorts of transaction in various sectors of health system is advised and needs to be assessed in relations to specific characteristics of those transactions. And another direction in terms of this is adequacy of institutional arrangement, and sometimes it is called transaction cost economics. This is in addition to price of goods and services. Transaction cost also includes searching for suppliers, negotiating contracts, keeping track of performance, and enforcing agreements. Like in Ayushman Bharat, in which incentives and price of various tests, medicine and medical procedure is fixed by stakeholders, that is very rigid. Okay. And it is also helpful to apply the agency ideas to better understand the incentives in a given set of arrangements. This aims to gain insights by examining the interaction between the principal and the agent, and who is a principal, who is considered to be the owner, whereas the agent are the manager. And we used to read principal agent problem in valuation of any services, but in largely the owners has little idea about the functioning, though most of the valuations are actually observed by agent. But so far as sharing of the incentives are concerned, agents and the share is considered to be lesser, very negligible. Even if in private healthcare structure as well, incentives is biased towards the operand of the functioning, especially the owner or they are the principals. So, when the incentives are not clearly defined, so the efficiency is considered to be questionable. So, managers are actually compromised or sometimes at the prey of non-distribution of the incentives. So, that is typical the problem of principal agent problem. Okay. Similarly, I think I have already discussed largely this, and but in public which chooses especially the policy makers, the public is the ultimate principal in the public sector. In applying a qualitative agency analysis, there are a number of questions that is helpful to ask of a given situation. So, especially the question is, where are the agency relationship in the system? There is multiple relationship that can be analyzed from different standpoints. Like under insurance, we usually consider agent to be the enrollee, okay, and insurance company wants the enrollee to avoid the risk of its risk on its behalf. Hence, however, there are other in which the insurance company is the agent of the enrollee, and most notably in carrying risk. So, agency relationships are often but not always reflected in financial flows to the extent where money is transferred and there is associated expectation that goods and services will be provided according to the direction of the player. So, player is not incentivizing enough to the enrollee. Hence, the effective reaching or the acceptability by the buyers for the scheme may not be actually perfect. So, money need not be involved, however, regulatory transactions also matters so far as incentives structures are concerned in that case. Another question is what are the information asymmetries in the relationship and where are the common uncertainties. In the doctor patient that is even in this case agent and principal relationship, principal is our patient, the doctor is better knowledgeable than the patient regarding the best course of treatment for the patient condition. However, there are common uncertainties about how well any course of treatment will work. Therefore, there will be huge doubts on the system, okay, because of uncertainties. So, it is not just the principal agent problem, it is also coupled with the information uncertainties. Due to these, the patient is unable to determine if the doctor behaved in their best interest even after the fact. So, we have discussed the incentive structure, we have discussed private and public relationships so far as health system is concerned, and we have also discussed about the evaluation for the health services through marginal social value, and hence we define the concept called optimum funding level and underfunding level. So, these are always essential, and to have a better efficient health system, we should have better incentive schemes, and that must be addressing the optimum funding level as well, optimum social valuation for the demand, etc. And in addition to that, the incentive schemes are always catalyst for the performance, and that is not just possible unless we do not define the public and do not segregate public versus private, and the principal agent problem has to also be dealt. To address these answer and to understand these questions or discussions, and we'll set some questions also at the end, and I am sure you can able to answer, and these readings you can also follow further. We have marked 2 important readings with page numbers are also written and chapters are written from the book. I think these are very essential, and what is for our next lecture we will be discussing on theory and evidence around options for financing a healthcare system. We will also discuss their strength and weakness, especially emphasizing financing healthcare system through taxes or through social health insurance schemes. With this, it is time to close. Thank you.